Hi, Matthew Holt with the Healthcare Blog, another THCB Spotlight, and I'm here with Lynn Rapsilber. Lynn is the CEO of NNPEN, which is, I'll get this right, the National Nurse Practitioner Entrepreneur Network. And obviously, Lynn, you're a nurse practitioner yourself. So welcome to THCB. Why don't you tell me a little bit, first off, before we dive into what the network is and what you're doing specifically in sort of business, and you're a nonprofit and you're working on that, remind people what is a nurse practitioner compared to a nurse and compared to a doctor? Just what's the basics? What does a nurse practitioner trained to do? How they're qualified? How many years of training do they have? What do they work on? Just give me an idea.
So thank you for having me, Matthew. It's great to be here. So nurse practitioners are nurses who have advanced degrees, advanced study. So we start out as nurses and then we go on to get an advanced degree as a nurse practitioner. Some of us are master's prepared and some of us are doctorally prepared, but we can assess, diagnose, and treat common healthcare conditions. We have a scope of practice that we work in. And we provide mostly primary care and psych mental health care, but we're also diversing into specialty care because we're population focused. We're not disease specific. It allows us to be able to provide care along a continuum. And there are a lot of us out there. Last year we were about 385,000, and this year we're now at 431,000 nurse practitioners. So our workforce is growing exponentially, and in the light of provider shortages, it's good to know that there are a group of providers that are actually increasing their numbers to meet the demands that healthcare is going to require.
No, that's fascinating. Actually, when you told me that offline that you were growing by more than 20% a year, that's pretty incredible, and actually it's very interesting. So just to be really basic, if you're a doctor, right, you go to medical school for 4 years and then you go through 3 years of residency usually. Most general practitioners will come out of that. Compare and contrast the sort of time that between nursing degree and then extra training for NP, and is there a residency associated? What's the progression for an NP?
So you have to be a nurse before you go into being a nurse practitioner. So nursing can take different pathways. You can be a diploma nurse, which I was that route. That really doesn't exist anymore. You can be an associate degree RN, and then you get your bachelor's. That's 4 years. And then you get your master's, which is 2 years as a nurse practitioner. Some of the programs offer an accelerated track where you get a bachelor's degree in something and then you can become a nurse and then a nurse practitioner. But the training is we always start as a nurse and we build upon that education as a nurse practitioner.
And what's the actual nurse? So now I've got my nursing degree. I'm a BA, master's sort of nurse. What's the next step in terms of nurse practitioner qualification and then going on from there?
So nurse practitioners, there's different tracks that you can take. So there's a family nurse practitioner track, there's an adult gero nurse practitioner track, there's an acute care NP track, an acute care adult gero track, there's a psych NP, women's health. So there's a lot of different pathways that a nurse can go into becoming a nurse practitioner. And it really is that population focused track that you take. The doctorally prepared nurse practitioner, some of us go back for an advanced degree like I did. And you can have that in nursing leadership, where you learn about healthcare finance and more of the leadership opportunities that are out there. You can be a PhD and do research. You can do an EDD, which puts you into the education. You can have a Doctor of Science. So there's different advanced degrees that you can have within nursing as well. But when we graduate from our NP training, we are qualified to go out and start practicing, assessing, diagnosing, and treating the conditions for which we're trained to do.
So if you were to do a family practice NP training, how long is that period of extra training on top of the nursing?
So you have your RN, which is typically 4 years, and then you have 2 additional years in your master's training.
Okay, so it's another couple of years in general. Mm-hmm. No right. Residency associated with it, as you said, or you could go that route, but not usually. Is that correct?
So there are some residency programs that are out there. I know my colleague in Connecticut, Margaret Flinter, has one specific for community health centers, and there are also other types, but they're not required to get into being a nurse practitioner. Once you're graduated from that particular program, you can sit for your boards, and then you're certified to be able to practice. These residency programs are additional educational opportunities that present themselves after graduation.
Okay. And then in terms of, so now you're out, you're training, you're an MP. I know many MPs are working in other clinics, alongside doctors and nurses, of course, as well. But what's the legal limit on the scope of practice between an NP and a physician?
So I guess that what I need to say is that physicians and nurse practitioners are trained in two different models of care delivery. So the medical model is disease focused. The nursing model is a holistic approach to healthcare where we look at, all facets of that patient, in addition to the diseases or chronic conditions they may have. So it's a different model, but the models do overlap in a lot of ways. Like there are opportunities where physicians do more nursing stuff and then nurses do more physician. So I think that's where there's this overlap in the cares that we do provide across the board. Nurse practitioners have a scope of practice, and that scope of practice is dictated by the state. So we have I think there's 29 states right now that offer full practice authority for nurse practitioners. And there are some states that have a transition to practice where they may be limited as to number of hours and they have to be under a physician or nurse practitioner. So for the most part, the practice authority is dictated by the state. There's regulatory requirements. But during COVID, with the public health emergency, all those barriers were gone because we needed nurse practitioners to be able to mobilize throughout the country to go where the needs were for care. And it's interesting since the public health emergency ended that we're trying to put the genie back into the bottle when, right now there were no issues of, issues of concern when these NPs had full practice authority during COVID. So, and we all need to have people practicing to the top of their education and training. And unfortunately, NPs don't have that luxury in a lot of states.
So when and I think that's an interesting point. But so let's think about what the typical. So you mentioned 450,000 MPs, so a lot of them, and compared to around 1 million or so physicians total. What are the majority of them doing? What kind of situation they're working? You mentioned a number of states. I know some of the big ones like California still have. Mean they have to be under the guidance of a doctor, although that seems to be how that actually plays out seems to be quite loose in some cases, and in some cases, as you mentioned, it's not necessarily, it wasn't necessary under COVID and isn't necessary in 29 states. But what are the typical roles that they're doing? What kind of functions is a typical nurse practitioner playing?
So nurse practitioners are licensed independent providers, and we can be found in hospital settings. We can be found in physician offices. We can have our own practices. We go where the care is needed. So we'll go to patients' homes, schools, daycares. We had somebody who is providing primary care in a megachurch. So we're not limited by geography and we're not limited by the patient's location because we tend to go where the needs are. And a lot of our NPs are looking at what their communities need and trying to fulfill. And nurses by general are problem solvers. So we'll see those needs and we'll try to go and do what we can to solve some of those problems. And access to care is a huge one right now.
Sure.
Most of the NPs are trained in primary care.
Yep.
And then psych mental health is the other area where we see tremendous growth. And a lot of the NPs that are psych mental health providers are really out there, providing that service independent. And they're really taking care of therapy and med management for a lot of patients. So you kind of get the best of two people in one person when you have a psych NP because they can do the therapy and the med management.
And are most of whether it's psych NPs or the family practice nurse practitioners, are they mostly working in other medical groups? So they just one of the big team. I mean, I know that for sure that I'm one medical member, and frequently they'll say, you can come see this nurse practitioner, or there's a nurse practitioner staff in the emergency line frequently. I'm just trying to figure out how if you were to take the several 100,000 there are. Is that where you'll find the vast majority of them, or the vast majority of them working, in community health centers? And then we'll get into it in a second about some of the level of independent nurse practitioners. I'm just trying to give a broad brush to the listeners of where most NPs are.
So I think where you'll find most NPs are in hospital-based settings and outpatient office settings, community health centers, rural health clinics. And what they'll do oftentimes is when they reach a level of experience, they'll start to say, maybe I should be out on I could do this on my own. And they often, look for an opportunity maybe to fulfill that kind of need. The other thing that's happening is that healthcare is changing and it's becoming more productivity based and seeing a lot of patients. And when you think about a nurse practitioner and looking at a whole person, we can't really do that in a 15-minute visit, so we tend to burn out quicker in that productivity model. And a lot of NPs are saying, I can't do this anymore, I need to step away, and I really want to start a practice where I can give the kind of care that my brain is hardwired to deliver in that nursing model.
So what's your estimate now the number was sort of 380,000 this year or whatever of NPs. What's your estimate of how many of them are running their own independent practice or an NP only group?
It's a fantastic question because we really don't know. These nurse practitioners are providing phenomenal care, but we just don't know where they're doing this. And many of them are doing it with their head down and they're just moving forward to provide that care to patients. But we're finding that, at least at the National Nurse Practitioner Entrepreneur Network, that we really need to start to coalesce our NP entrepreneur colleagues so that we can actually start to create connective tissue, work together and support each other, and really work together, because an N of 1 with 500 patients really isn't going to have a lot of, bargaining power or leverage, where if we have N's of 1,000 with hundreds of thousands of patients' lives, now we're talking. Now we can actually start to look at how can we, as NP practice owners, how are we making a difference? How are we saving money? How are we keeping people out of the hospital, ER, and urgent care?
So, I mean, a couple of things worth noting, right? Which one is that there are a lot of places in America, both in urban but also heavily in rural areas, where there isn't any primary care, and we're short of it. And this obviously is a big potential solution. We've been, the second is that MPs actually get paid less by Medicare, right, than the same for doing the same thing essentially, for the fee schedule. Is it 20% difference?
So physicians get 100%, we get 85%.
Okay, so it's 15%. 15% less.
15% less.
I can never do the math. It's 15% less, and then you have to get paid 20% more to make it up, or whatever.
Anyway. Well, that's just it. I mean, we're already starting at a budget deficit once we open up our practices. So, again, it becomes more challenging for us to try to be sustainable when we're opening.
But have you found that for independent NPs running a practice, like primary practice, that is it a sustainable business? I understand.
It can absolutely be. And I think one of the things that we're trying to stress is that Medicare, Medicaid, and the rural populations, uninsured, those are the folks that really need care.
Sure.
And we're poised to provide that care. But we also realize that that is not going to pay the bills. So what we really need to do is look at how can we supplement by providing VA disability ratings for the veterans, because that is a backlog. These veterans have been waiting, to get their disability ratings for years. So that is an opportunity that we can help fulfill a need with a population that needs that. Weight management is another area. And it's not just prescribing the GLP-1s and, take the shot and you'll be great. It really is looking to lifestyle change and how you can do that with a patient. There's opportunities to do aesthetics. There's opportunities to do employment physicals, DOT physicals. There's a lot of different add-on services that you can provide. We had one nurse practitioner who worked with a company to do fit testing. They worked with chemicals and they have to have the masks that fit properly. So that MP went into that company and helped the employees get fitted for their masks. So there's a lot of other opportunities to do add-on. The other thing that we do too is if we're doing a visit and we're seeing a patient for 30 minutes or an hour, there are other services that we can provide to that patient during that visit that are add-on services that actually will help increase the reimbursement that an MP might be able to ascertain just by spending that extra time with the patient.
Yeah, and I guess this leads to the question of, and I'll get on to what you're particularly doing in a second. But there's a couple of movements going on in primary care, right? There's one is building out, and it's usually hospital or private equity center building out urgent care centers.
Mhm.
There are a few bigger primary care groups. I'm thinking about the ChenMeds and the Oak Streets who've been aiming at Medicare Advantage, who've been building big teams. I put One Medical in that bucket, although it's a slightly different thing. And then there's this emergence of direct primary care, which is basically it's membership cash
Mhm.
pay,
Right.
from individuals. Have you seen? I mean, it sounds a lot of that has the 30 to 60-minute appointments and
Mhm.
smaller panels. Have you seen any MPs go into that model? Or is there a sort of direct primary care model for MPs to charge rather than just doctors?
Absolutely. Direct primary care is a model. Functional medicine is another area where
Yep.
NPs are really gravitating to a lot because we want to look at all different opportunities to provide care to our patients. We're not running to provide a prescription when somebody walks through the door. We're going to assess them and see, what's your diet like and are you exercising and what's your stress level and really, look at that whole person and really tailor a treatment plan that's going to work for them as an individual. And that does take time to do that. But there are opportunities for NPs as well. Some of our NPs are opening their own urgent center clinics. One area that I find that NPs are gravitating to is called transitional care management. So they will see those patients that are being discharged from the hospital within 7 to 14 days so that they can help reduce the hospital readmission rates. And that's a big plus for a rural hospital community to make sure that those patients don't get readmitted. So NPs are instrumental in starting a practice along that lines as well. Home-based primary care is huge. A lot of our NPs go to the patient's home and do an assessment there. And it's great for somebody who can't get out of the house. If you're overweight, and it's difficult to get out of the house, those are the right patients. If somebody has um, mental illness or Alzheimer's, where taking them out of their environment is going to stress them out, it's great to have somebody be able to come to their home and see them.
So a lot of opportunity then for nurse practitioners. Are there people, and before I'll ask what you're doing, but are there people building sort of NP groups in terms of where a lot of them are coalescing together in an area similar to a typical medical group, or are most NPs who work in a group working in a more traditional medical group with doctors and others?
So a lot of NPs are breaking away from the medical group practices
Right.
and things like that to start their
Well, I'm wondering,
own.
so they go into groups of with other MPs, or is it almost all independent?
Well, what our hope is that if we can connect a primary care nurse practitioner with a psych mental health practitioner in a community to share resources, that's going to enhance the care that community is going
Sure.
to have. So that's kind of our goal with our directory is really to link and coalesce these NP practices from across the country so that we can find out where these clinicians are located. Patients can find them because they're always looking for NPs and don't know where actually to go to find them. And then they're looking for nurse practitioners to collaborate with each other to provide referral sources or to share resources, and then students to find preceptors because we're finding a lot of NPs that are students want to go into a practice that's led by a nurse practitioner.
Yeah.
So our directory actually is set up to do all that.
So tell me a bit. So let's dive in. Tell me a bit more about what the network, as a reminder, it's the National Nurse Practitioner Entrepreneur Network.
Yes.
A bit of a mouthful. NNPN, NNPEN. Some of that is a for-profit business you run. Some of it is a non-profit with the directory.
Correct.
Go on the list of what do you provide? What
Sure.
services are you doing?
Sure. So, our vision really is to elevate the nursing model to transform healthcare delivery by creating financially viable and sustainable community of NP entrepreneurs. And our focus really is we started in 2017. We're over 300 members and we're continuing to grow. We provide a business basics accelerator course because one thing we do not get, nor do PAs or physicians, is business education.
Sure.
So in order to be successful, you have to know that foundational and have that mindset to be an entrepreneur. So since we've started our business basics course, we've launched about 70 NP-owned practices. We've hosted over 7 national conferences. We took on our first state affiliate in Florida recently. We have ongoing meetings for members relating to primary care and then also psych mental health. And we're advocates for the NP entrepreneurs as policy and advocacy. And we also partner with entities that really understand what nurse practitioners are in the nursing model of care. So that's our for-profit arm. And then we started our not-for-profit, which is our Destination NP. It's our 501c3. And that directory really serves several purposes. As I said before, patients can find nurse practitioners. Nurse practitioners can find each other for collaboration, for referrals, and for support and resources. And then students can find preceptors. And once the nurse practitioner is on the network and all they need is their NPI number to register and they get into the listing, the goal is to try to aggregate as many folks on the platform as we can. And then actually, as the platform grows, we'll be able to offer much more in the way of opportunities for NPEN members to participate, whether it's being expert panel opportunities, because I'm getting every day, I'm getting calls from people who say, I want to work with your group. I have this software or this app. Can I test it on your NPs? I'm a researcher. I need access to NP practice owners. So there's a lot of opportunities for folks when they're on this system. But the biggest thing is creating that community of NPs so that we can start to aggregate and really be able to speak with one voice. For the NP entrepreneurs. That's the really key thing, because right now everybody's doing their little thing in isolation, but once we, coalesce together, that's going to give us a lot more leverage, I think, overall. And then we can start looking at what are the outcomes that our NPs are providing. There's data out there, researchers are looking at that, but if we had a larger database, that would actually, help in that regard as well.
There's a lot you can do on the nonprofit side. Just getting back to the for-profit side again.
Mm-hmm.
So you're providing education, you're providing sort of a setup system for MPs to go to business and some other consulting around that.
Mm-hmm.
What if I'm a nurse practitioner working in a medical group and I say I want to set up my own business, and I come to you and say, Lynn, can you help me?
Mm-hmm.
What does it cost me to sort of go through your system, and
Sure.
then what do you think it costs me to get into business as a whole?
Sure. Yeah. So our membership rate is very reasonable. It's $198 for the year. And with that, you get 1 hour free consulting to meet with one of the founders. And what we can do is help. A lot of people have these great ideas, but they're not being able to hone it down to one thing that they could start and do. Or they want to start right away and get a brick and mortar and do all this. And it's like, well, wait a minute, that costs money, and that's not easily accessible to us. We can't just go into a bank and say, hey, I want $250,000 to start a practice. They're going to go hit the road. But what we can do is talk to them about maybe start with telehealth or start with a home-based practice and then build from that. We help them with marketing. We have partnerships with marketing, credentialing, billing, EHR, and a lot of the support network. We're building a lot more of the infrastructure to help NPs to be sustainable. We do an office hours. It's the third Tuesday of every month where we highlight a hot topic. And if you're an NPEN member, you get a free CE for everyone that you attend. They're all recorded, and we have about 4 years worth of content. That's amazing. Everything that you can think of regarding practice ownership. The other area that we partner with is the Nurse Attorneys Association, because with practice ownership comes a lot of legal things.
Right.
So, whether you're buying a practice, selling a practice, maybe there's a complaint filed, we'll now have access to nurse attorneys that can help our folks, be compliant and stay out of that legal area. We don't really want to go down that rabbit hole if we can avoid it. So those are some of the benefits that we offer our members. In addition, things like the physician fee schedule is out now. So I because my area of expertise is coding, billing, and documentation, I review the changes. I put out a notice to our NPs with a nice little letter that they can send in to comment on and add in their own personal stories as well. So we're trying in the advocacy of policy arm as well. And we also have a lot of recorded content from webinars regarding value-based care, when the government knocks, coding and billing, both for primary care and mental health. So there's a lot, and then we're constantly building upon that. Our Business Basics Accelerator course, we're actually looking to partner with a university to create that second level. So when that NP starts and they get into year 2 or 3 and they want to grow, that comes with other challenges. How do you find right employees, and how do you, grow your business? So we're going to be working with a school of business to create that content. So, I mean,
there's a lot.
we just keep moving forward. It's amazing. And it's so funny because when we think that, we're concerned that we'll ever be able to get forward, we always say the universe provides for us, and it always does, and it always has. And I think because we're, committed to NPs and NP entrepreneurs, I think that's where, we want to be the trust agent for the NPs, that they can feel comfortable that we're a safe space. We also have a discussion board internally too, where our members can communicate with one another. I troll Facebook a lot, and I'm always interjecting. Join our network.
Right. So let me ask you some of the mechanics. If I'm sitting as an MP and I'm working for a medical group or whatever, and I'm making X. Actually, I don't know what X is, but I'd be interested in what you think on average they're making. How much is it going to cost me to go into business myself?
Mhm.
I can't buy your stuff, but there's always a bunch of other expenses. And
Yeah.
what's the average reasonable amount I expect to be able to make as a solo practitioner instead? Can you give me a sort of sense of what the business opportunity there is for them?
Yeah. So again, it really depends on where somebody's at.
Sure, it's going to be
Yeah.
different by community and average and all the rest of it. But to give me a sort of sense about roughly what we're talking about here.
But to do a telehealth or a home-based primary care, you could probably do that for $5,000
So not too
easy.
much to set up, and
So
then
it is right.
and then
And then
roughly what are they making? Roughly what's the range of what they make an NP makes in a practice working with somebody else, and then roughly what do you expect them to make working with themselves?
so again, if you are in a medical practice, you're going to make probably, anywhere from 125 to 150,000, somewhere in that regard. When you're and when you're in your own business, you'll make that money. You'll keep all that, because when you're in a practice, they're going to skim off all the overhead costs and things like that, where that's going to go in your pocket. And then we try to educate them about being part of the quality payment programs where they can get bonus money for the quality care that they provide. So we really try to work with them to maximize the coding and billing side of things, and to look at other opportunities like these quality measures
Right.
where they can actually enhance. We're also looking at being able to be part of REACH ACOs and some of the other, CMMI innovation models that look for nurse practitioners to maintain elderly or high-risk patient care. That's been very popular. I would love to see, once we get this database up, to be able to create a pilot project for CMMI, where we can look at our nurse practitioners and put them into a different type of ACO model, and see what they can do.
Yeah, and I would also think that given the advances in AI, the
Mhm.
ability of a MP to extend, and for that matter, for a doctor to extend their practice, do a lot more from a sort of solo or very small group level. We're going to see a lot more models coming up like that. Um, so just to end, so as you said, we're creating a lot of MPs.
Mhm.
They're all, as we discussed, in many different environments, in many different places. But all this comes down to the fact that we do lousy primary care in America. We don't do good holistic care.
Yeah.
What's your kind of vision for pushing this forward? For both what you're doing
Mhm.
and the general movement for MPs and primary and improving primary
Mhm.
care. What's your vision? This looks like in 10 years' time. Give me a sense of what you think is going to
So,
be.
yeah, that's a great question. As a matter of fact, it came up in a program that I was sitting on, where they were talking about redefining primary care. And
Mm.
what I can foresee is, right now we're in an illness care model that is really structured more, and people enter the system when they have a disease. And what we really need to do, and that's what value-based care is based upon, is how can we move that care from the hospital side and illness care to wellness care, where we're looking at health promotion, disease prevention, and really empowering the patients to take some charge and ownership of their care. And the only way to do that is not the transaction of the medical model, but the longitudinal of that patient relationship with that nurse practitioner. And there are a lot of great physicians too, by the way, who are doing this kind of care. But it's really getting that longitudinal and that relationship and partnership with the patient that's going to pay the dividends in the long run. And that model has to stand up. And I think that, right now we're stuck in this medical model. It's too expensive and it's not going to provide the outcomes that we need. We need to let the nursing model and that value-based care model, let that try and see how much of a difference we could potentially make if we look at shifting the conversation from illness care to wellness care and health promotion, disease prevention.
Yeah, I've written a bit about this, and can we get primary care to everybody? Can we get, essentially the level of direct medical care where people are on a 500 panel, it's not sort of a 2,000 panel, and where people get access to primary care, and how much difference that would make downstream in terms of lower resource utilization and better care and better preventative care. And you've got to imagine that the people who are primary care doctors and current MPs, and as you mentioned, behavioral health MPs as well, because that's a big part of this. There has to be a solution for that, for those hundreds of thousands of clinicians. Can we not create a way that, because we know the intensive sort of medical model and frankly the bastardization of it over the last couple of decades, where hospitals have bought up medical groups and primary care groups just to ensure they get a flow of patients into their expensive stuff inside the hospital, the surgery, and the infusion, the chemo care, and all that kind of stuff. And it seems to me that that we have a great opportunity with the growth of MPs, to kind of reverse this primary care collapse, or whatever you want to call it, and
implosion.
Collapse, implosion, and you're right that maybe the REACH ACOs are a slight move towards that, and some others, but I think people are looking at this. I mean, I think right now the Alpha Zeta conference is going on in Denver, where they're talking about many of these same things, and there is a general understanding that the way we've done primary care isn't working. And I think what you're doing and what your organization is doing is sort of being one of the points of light to see how are the ways we can change that. So good luck in what you're doing. I know it's an uphill battle starting a relatively small organization and getting awareness about it, but I think you're doing you're doing good work out there. So
thanks. Well, we're firm believers that we can change healthcare from the ground up, because top down doesn't work. And so, meeting patients where they are, solving problems in the communities, that's where I think we'll see the best, the patients to take some ownership of their own care and their decisions, because right now that's not really what's happening. In theory, that's what patient-centered care is supposed to be like, but it isn't. And I think if we can empower those patients to partner with whatever provider they have, whether it's a nurse practitioner, PA, or physician, that in and of itself is going to change healthcare as well. And who knows, what's going to happen in the next year. We're seeing a lot of change right now, and a lot of tiptoeing to see where everything's going to lay out. But I really believe that if nurse practitioners are meeting needs in the community and providing that care, patients are going to know that that's going to be helpful, and the insurers are going to latch on to this, because once they figure out that we're keeping people out of the ER, urgent care, and hospitals, why wouldn't you want to have a whole panel of nurse practitioners providing that care?
I hope so. I'm not always sure that leaving off safe in the American insurance companies is the best way to go, but we'll see.
True.
But I certainly like the vision. I've been speaking with Lynn Rapsilber. She is the CEO of the NNPN, a leader in helping nurse practitioners develop, and as we've been discussing in the last 30 minutes or so, really interesting time in the future of primary care based on what nurse practitioners are going to do. Thanks for your time, Lynn.
Thank you. Appreciate your time as well.